hospital. So my topic today is very familiar to you, I know. PNF. Anyone who haven't encountered the word PNF or Propioceptive Neuromuscular Facilitation?
Yes.
Anyone?
Yes. We heard of it.
I think everyone encountered this type of technique, Propioceptive Neuromuscular Facilitation. So to start with, the lecture's objective is to describe the PNF basic principles and philosophy, to identify basic PNF patterns and its nomenclature or naming, okay, and to describe the relationship between the upper and lower limb PNF pattern with the trunk responses. And the lecturer, the participant will be able to identify some of the basic techniques used in PNF. And lastly, to identify some practical and clinical application of PNF. Okay? So we will go a little bit faster because the lecture is a little bit lengthy. Okay? So what is PNF? Okay? What comes into your mind when you say PNF? What comes first into your mind? Diagonal movement, correct. Yes. Actually, this PNF is not only diagonal, it doesn't only talks about diagonal movement. Later on we will find out, okay? First, what is PNF? PNF is a approach or technique designed to enhance the response of neuromuscular mechanism through stimulation of proprioceptors. So it uses a pattern, a diagonal or spiral direction of movements. Okay, more on spiral with rotational components. Okay? So unlike the other conventional exercises which uses the stereotype movement, flexion, extension, abduction, this is a combination. Okay? Okay, we have a brief history for PNF. PNF was developed by Dr. Kaman Kabat and Ms. Margin Nutt, who is a physiotherapy, in 1940. This irradiation was popularized by Charles Sherrington way back in 1900s. So initially they used this approach in treating MS or multiple sclerosis and polio patients. Okay? And later on, it was used to, even for sports, okay? Rehabilitation, and even for other diagnoses like neuromuscular cases. Okay? So PNF philosophy. The philosophy for PNF, there should be intervention should be toward a specific functional goal. It uses repetition to promote motor learning and a positive approach that focuses on what the patient can do. Okay? And it facilitates a maximal responses and incorporates the use of stronger body parts to strengthen the weaker ones, which is, we call it irradiation. Okay? So in order to perform PNF effectively, okay, we have to use the basic principle. We have to follow the basic principles of PNF. Number one is patient position. So the patient should be in a correct alignment. Okay? And the patient should be in the position where it allows him to do the functional task. Okay? Number two is the manual contact. This is the hand placement of the therapist. Okay? It guides the patient. It gives the direction of the movement that will be done by the patient. Okay? Another, the therapist should be in a good body mechanics. Okay? Sorry, that is in therapist position. Okay? The therapist should be in a good body mechanics. Okay? And it follows the movement desired towards the patient. Okay? Another basic principle is that appropriate resistance. Sometimes we give resistance, but it is not appropriate. Maximal resistance is not always an appropriate resistance. There is a question before that we apply PNF, but the tone increases. So meaning you are not applying the appropriate resistance. It should be the appropriate resistance. Sometimes appropriate resistance can be an assistance. Okay? So active assistive, like that, range of motion exercise. Another basic principle is traction and approximation. Traction, okay, it is a gentle force applied away from the body. So meaning to say, this principle is that traction facilitates movement. The other one is approximation. So apply gentle force towards the body. This is facilitate stability. Okay. Another principle is quick stretch. Usually this is to stimulate proprioceptors. Okay. It is done in the beginning of the range. Okay. Irradiation. This is using the stronger body parts to facilitate or to influence the weaker one. Okay. It creates a motor, overflow of the motor response to the weaker muscle. Okay. Later on, I will show you video how these basic principles is integrated. Okay. Timing. This is how when the movement will be done. Okay. And how the movement will be done. Okay. It can be from distal to proximal or proximal to distal. It depends. If it's open kinematic exercise, usually from distal to proximal. And if it's closed kinematic, from proximal to distal. Okay. PNF pattern. Of course, we have this diagonal movement, okay, incorporated with the rotational component. Okay. Visual and verbal input. Visual cues. This guides the patient in which movement you will perform. Okay. And this increases the response of the patient. And verbal also. Okay, the command to your patient. Okay, you can modulate, increase your voice or decrease your voice. It increases the response of the patient. Okay, this is the video I'm telling you. Before performing the actual pattern, you have to do it passively to the patient in order for the patient to know which movement you are going to do. Okay? So he will be aware about the movement. Okay, this is an actual patient I have in Ward 4. He is hemiplegic patient. Hemiparesis now, and see at the start of the movement there is quick stretch going towards the end of the movement. Okay, so this is the basic PNF patterns of the limb. So later on we have also the pelvis and scapular limb patterns. So for the patterns, it is named based on the ending of the movement, where the position of the extremity ends. Okay, in the proximal joint. So here we have the shoulder. Okay, shoulder in flex, adducted or externally rotated. Okay, this is according to Kabat, they name it D1 flexion. Okay. The opposite is D1 extension. Okay, D1 flexion, D1 extension. So, and we have also D shoulder is in flex and abducted and externally rotated. And D2 extension, the shoulder is in extension, abducted and internally rotated. Okay. So the important thing here is what is the response of the trunk in connection to the upper limb. Okay. Flexion of the upper limb usually facilitate extension of the upper trunk. Okay, see? Flexion, D1 flexion, trunk extension. And any movement pattern towards extension, upper limb extension, it facilitates flexion of the trunk. So, see? From extension, it becomes the response of the trunk is flexion. On the other, on the lower extremity, okay, it is described also the same as the upper extremity, in which the pattern is described based on the position it ends. In the hip, the hip is in flex, adducted and externally rotated. It is named as D1 flexion. Okay, are you getting what I mean? Okay. D1 extension, the opposite movement. Okay. The hip is in externally rotated, abducted, and internally rotated. Okay. Also the ankle and toes, there is movement. Okay. So the D2 flexion, the hip is in flex position, abducted, and internally rotated. So what is noteworthy here is that the flexion of the lower limbs facilitate extension of the flexion of the lower trunk. It's a here is vice versa. This is same. Okay, flexion of the lower limb facilitates flexion of the trunk. Okay, so we'll go ahead. Okay, we'll go for the scapular pattern. I think maybe you know this pattern, scapular and pelvic pattern. Okay, but okay, same as the limb, it is based on the position it ends. So this is the scapula. Okay, in a sagittal plane, okay, the scapula can be segmented into anterior and posterior. Okay, anterior and interior the depression. So as the PNF is in a diagonal movement, the scapula should be moved in a diagonal pattern also. So from, let's say example, anterior elevation. So the movement should be towards this side, okay? It starts from the posterior depression towards the anterior elevation, okay? So we can see it in the functional application for this one. So anterior elevation, it can be incorporated with the limb D1 flexion. So like this, okay? So this is to improve rolling, overhead reaching, and activity. Later on, I will show you how it is performed. Okay? So we have also the movement of the scapula toward posterior depression, or we can incorporate it with D1 extension with the upper limb. Okay. Okay. This one promotes weight bearing in the upper limb, and it will be used for sit to stand activities. Okay, like this. Okay. Okay. This is some videos just for us to appreciate this scapular movement pattern. Initially, the patient should be, the movement should be shown to the patient. I mean, it should be done passively to the patient for the patient to be aware of it. So, this is scapular anterior elevation. Okay. You notice that there is quick stretch before the movement. Okay, to facilitate this. This one is same scapular anterior elevation. Okay, I just put short videos just to. Okay, this is a scapular anterior depression. Okay, see quick stretch, then going towards anterior depression. Okay, quick stretch. What? Okay. This is to facilitate rolling. It's very important and used for rolling. Okay, it enhances rolling. This is scapular posterior depression. Okay, see, a quick stretch, then patient will be moving backward and posteriorly, inferiorly. Okay, so this can be used for stability from sit to stand. Okay. Another is the pelvic pattern. If there is the difference is that pelvis is a fixed, okay, movement. There's less movement, most probably fixed. Okay, same is true. There is anterior of the pelvis and posterior of the pelvis. Okay, anterior scapula, the movement is anterior elevation or posterior depression. Okay. So for functional, we'll go for the functional application. For example, anterior elevation, it could be incorporated or combined with D1 flexion of the lower limb. Okay, this facilitate or improve swing phase of the gait, rolling trunk flexor activation. The other one is the posterior depression. You can incorporate it in D1 extension of the lower limb. This is to enhance instant instance stability and trunk elongation. So I have also a video for this one. Okay. This is for pelvic anterior elevation. Okay. Okay, your hand placement is on the anterior of the iliac crest. Okay, anterior of the iliac crest. Okay, before the movement, quick stretch. Okay. It also used in rolling activities. Okay. Okay. The hand placement is on the ischial tuberosity. Okay. This is pelvic posterior depression. Okay. Later on, we will see there is a combination with scapular and pelvic. We'll see. Okay. Okay. Some PNF techniques and practical applications. So, to enhance the treatment for PNF, we have some techniques. Okay. Numerous techniques, but I choose only 3. We have contract relax, hold relax, too much techniques, but I use 3, which is common also. Yes. We have this rhythmic initiation. Usually, this is to teach the patient the pattern for movement and help the patient relax. So you can do it initially by passive range of motion, then followed by active assistive, active range of motion, and resistive range of motion exercises. So later on we will see some example for this rhythmic initiation. Okay, for another technique is dynamic reversal. This is to promote endurance to a particular muscle group. It improves strength. Okay, it is done by a movement against resistance in both directions without stopping. Okay, the example for this one is the resistive trunk flexion and extension. Usually, resistive trunk flexion extension facilitate adaptation or movement of the lower limb. So, and it's used for trunk strengthening and preparation to sit the stem. Another technique is stabilizing reversal. This is to increase stability, strength, and coordination. It is done by alternating muscle contraction against resistance in general position. Example, it is in hook lying, okay, stabilizing reversal, which activates the trunk stabilizer and radiation. Okay, we'll see the video. For this one is the rhythmic initiation. Okay, initially you have to do it passively. Then patient will do it active assistively. Then active range of motion and resistive range of motion. But if there is a resistance given in all the direction, it will be dynamic reversal. Okay, this is to facilitate the. It increases the strength of the trunk. Okay, this is the hook lying, stabilizing reversal. Okay, so in this one, I'm trying to put resistance, okay, to the patient, and the patient will maintain the position, okay, of the extremity. Try isometric contraction, okay. I'm trying to put resistance in different direction, applying approximation and traction on the other side, okay, for stability.
No need any compression.
Compression, yes, there is compression because compression facilitates stability. See this one, this one
Resisting what?
compression,
Resisting what? Abduction, for example.
abduction, adduction.
And when you are making your hand like that, you are trying to, for example, flex the hip and he's resisting you. Or
No, this one is traction.
now you are doing this by hand, right?
Yes. This is applying traction, and this one applying approximation. The
What is
resistance.
Each movement you are going to upholding.
And did you observe something?
I just want to understand.
See, this one. I'm trying.
Pushing down and approximation.
Yeah, approximation and traction.
At the front
And
showing.
trying to open.
Oh, but that is resisting you.
Yes.
You know,
Stabilize.
you should, as well
He should not
contraction, right?
move he should maintain the position. So co-contraction, actually it's a co-contraction of the hips.
When you have
5 minutes.
5 minutes,
Okay, I hope this one. Okay, this is sitting with resisted trunk flexion and extension. Look at this one. You can notice with trunk flexion, the lower extremity moves. Okay, this is irradiation technique. Okay, facilitates movement of the distal part of the body. Okay, BLF can be used in breathing technique. Okay, we have two mechanisms: the sternal contact and the bilateral rib cage or the bucket handle mechanism. So in pump handle mechanism, usually this one is the pump handle. Okay, it resembles the water pump. Okay, the movement is of the sternum is superior and anterior. Okay, so this is the pump handle mechanism. And the other one is the bucket handle. Bucket handle. This is the bucket handle. It moves the lateral or the ribs, lower ribs into elevation and lateral side, lateral movement. Okay. So in PNF we can do that. We can use PNF. Okay. Your hand should be placed on the sternum. Before the inhalation, okay, apply quick stretch. Okay. Quick stretch. Okay, inhale. Exhale. You can apply also resistance during inhalation to increase the strength of the intercostal muscles or accessory muscles for
stretch
breathing.
where
Quick stretch.
you mean
Yes. See?
inward.
Yes. Sorry if it's small one. Okay. Okay, this is the bilateral. Bucket handle. Okay.
What is the order of giving intubation and what you?
Okay, you have to notice the breathing pattern, okay?
Yeah.
But before he will do the inhalation, apply quick stretch downward,
Downward.
okay? Inward, downward, okay? Okay, rolling. So the task that one of the patient, some problem is in rolling, have difficulty in rolling. So this is my patient. Okay. Okay, very good. Okay, go back.
Fine.
Okay. So going towards the right side, see, it's some difficulty. A retracted shoulder. Okay. Retracted shoulder. Okay. So I have to cut now. Okay. We have the combination of pelvic scapular PNF and the pelvic PNF. So we can use it in rolling. Okay. Okay, we call it mass flexion. It is done with the patient in lying position, side lying position. It increases the trunk flexion and forward rolling, and enhance cuffing because of the forced expiration, because we are exercising the abdominal muscles. Okay, the head placement should be on the shoulder, anterior to the shoulder, and near this thoracoid process and above the anterior superior iliac spine. Okay, we have also mass extension, which is used to facilitate backward rolling and trunk extension, thoracic extension. It is the patient's position is inside lying, and the hand placement usually in the posterior superior of the shoulder and the ischial tuberosity. So I have some videos here. Okay, so you can appreciate how this mass flexion is done. Okay. Okay. So, okay, before the movement, there is a quick stretch, okay, towards the anterior depression of the scapula and the pelvic anterior elevation. That is mass flexion to facilitate rolling forward. This is to facilitate backward rolling. Okay, quick stretch. Okay.
You have 2 minutes.
Yes. Okay, these are studies. I will distribute some papers, okay, for some questions. 3 items only, just to check if you understand my lecture. Okay. There are numerous studies done by choose few of them. The latest one, 2017. Okay. According to Deepak Joshi in 2017, okay, he done research on the effect of scapular PNF on shoulder pain, ROM, and upper extremities function in hemiplegic patient. It was a randomized control trial. In her conclusion, there is a scapular PNF has positive impact on post-stroke shoulder pain and range of motion. Helps in strengthening of proximal muscles of the upper extremity, thereby correcting scapular alignment and improving upper extremity function on the stroke patient. So we have numerous research. Okay, to summarize the lecture, okay, PNF is an exercise used to enhance neuromuscular response by stimulating proprioceptors using diagonal patterns of movement. It uses different techniques to enhance the movement pattern. Flexion of the upper limb facilitates trunk extension, and extension of the upper limb facilitates trunk flexion. And flexion of the lower limbs facilitates trunk flexion, and extension of the lower limbs promotes trunk extension. So PNF can be used in breathing and enhance functional activity. In my part, I choose the rolling task activity. Okay. So these are my references. Okay, thank you.
Thank you.
And should I post the some questions? Okay, just so that okay, we will answer. All are basic principle in PNF except C, rhythmic initiation. Rhythmic initiation is a technique, it's not a principle. Okay. Number 2, all of the following describe some of the principles of PNF except okay, C, it should be appropriate resistance. Okay. And lastly, this one is a case. 65-year-old male patient diagnosed to have Parkinson's disease, presented with difficulty to initiate movement and slowness of movement with some rigidity of limbs and trunk with typical stool posture. Based from the presentation, the most likely PNF treatment described for the patient will be what?
C.
Okay. PNF
B.
B. Okay. B. This one, huh? Because there is to facilitate trunk extension and rhythmic initiation because there is rigidity. Okay, it's difficulty to initiate movement. So the answer is B. Okay, thank
So
you.
why number 2 C?
Hmm?
Why number 2 C?
Appropriate.
Maximal, it should be appropriate resistance.
But in some videos you see that I'm doing isometric exercise for under retaining position, right? In some videos you
Yes,
see
yes, yes,
I'm
yes.
doing isometric
Yes, yes, yes.
Isometric means maximum resistance.
No. Isometric doesn't necessarily maximum resistance.
Isometric they cannot apply maximum resistance.
Isometric for position.
Isometric, if there is maximum contraction without movement. You can be 50% of the maximal resistance. You can
But for the
apply.
patient, it's much more resistance. For the patient himself, maybe it's little resistance, but for him it's maximum because it's too big.
It can be
Yeah, you have
applied
to
by the
control. You have to
manual.
control. You have to control.
That's why it's called proper. It's proper for the patient. Yani it differs from patient and another.
In the video,
You can
there is
advise also
something
the
called
patient.
Isometric, right? Isometric means what? Maximum resistance to prevent the movement.
Yeah, maximum for the patient.
Yes, maximum.
But the maximum differs from the patient and another.
I know, according to the muscle power.
Yes, this is what he means by proper.
It doesn't mean so.
Good. I have a question. You mentioned in the PNF technique for only grasp motor functions something. We can apply in the